Welcome to my review of renal pharmacology. I'm going to cover some basic concepts, and remember, this information is for educational purposes only and not medical advice. Enjoy. First, let me go over some basic concepts about making urine, which is what the kidneys do. Every day, the kidneys filter around 180 liters of blood, and it initially removes water and solutes out, which is a filtration. Blood enters the renal corpuscle of the nephron through a glomerulus of capillaries. The capillaries are surrounded by a structure called the Bowman's capsule, which absorbed water and most of the solute from the blood. The blood pressure from the capillaries pushes these into the capsule. If the blood pressure is too high, as seen as hypertension, the capillaries can weaken and harden, reducing the ability of the kidney to filter the blood. The next process is reabsorption, where nearly 70% of solutes, which are salts, glucose, amino acids, and bicarbonates, are reabsorbed back into the surrounding capillaries, so that nothing that is useful is wasted out into the urine and kept in the human body. The next step is secretion, which is a process where the vessels remove any remaining waste products from the blood back into the nephron and out into the urine. And finally, the remaining filtrate or urine is collected and excreted from the kidneys through the ureter. So let's do a quick refresher of the kidney structure. Here you have the glomerulus in the nephron. It receives blood supply from the afferent arteriole and exits into the efferent arteriole, not the venous system. This use of an arteriole to exit the blood flow out provides pressure for the blood to be filtered, since arterioles dilate and constrict more readily than venules. Next, we have the proximal tubule, and it regulates blood pH by filtering hydrogen and bicarbonate, as well as pulls out nutrients and minerals out of the urine back into the blood. The loop of Henle is divided into the descending loop and the ascending loop. The descending loop allows water to flow out easily into the interstitial tissue, whereas the ascending loop pumps sodium, water, and chloride out into the interstitial tissue. This creates a hypertonic environment that triggers the flow of water out of the descending loop and the distal convoluted tubule. The ascending loop is where loop diuretics like furosemide exert their effect. Furosemide blocks the reabsorption of sodium, chloride, and potassium, keeping these in the urine and pulling out water out with them. Finally, we have the distal convoluted tubule, which is where the final concentration of urine is completed. There's some reabsorption of sodium, chloride, potassium, and calcium, and to a lesser amount of water than in previous segments. This is where thiazides promote diuresis and cause the loss of sodium, chloride, and potassium. They block the excretion of calcium and uric acid, potentially being beneficial for kidney stones, which are high in calcium, as well as osteoporosis by limiting calcium excretion. But they can cause gout because of their effect on uric acid, which increase with thiazides. This is also the area that responds to aldosterone. It causes a retention of fluid and sodium. And this is where aldosterone antagonists, such as spironolactone, eplerenone, and finerenone, exert their mild diuretic and potassium-sparing effects. Drugs that block the production of aldosterone, such as ACE inhibitors, will have similar effects on urine production and potassium retention. To help remember the sites of action of diuretics, you can use the mnemonic MALT-K. Remember that the closer the drug works near the glomerulus, the more potent the diuresis. The first one, which is M for mannitol, it is a sugar alcohol and creates a strong osmotic gradient, pulling water out of surrounding tissues. It's used intravenously to lower intracranial pressure after head trauma. Its use required frequent lab monitoring, so it's reserved for areas like in the ICU. Next is A is for acetazolamide. It blocks the enzyme carbonic anhydrase, which leads to increased excretion of bicarbonate, HCO3, which carries with it sodium, potassium, and water. It alkalizes the urine and can cause blood acidosis. It requires frequent lab monitoring as well. It is used to lower intracranial pressure as well, and it's used for high altitude sickness. The enzyme carbonic anhydrase is also located in the eyes, and so acetazolamide is used to lower fluid pressure in the eyes, making it useful for glaucoma. L is for loop diuretics, such as furosemide. These keep sodium in the urine, which pulls water out with it. It's the main site of action is in the loop of Henle, in the ascending loop of Henle. Next is T is for thiazides, and here we get into the weaker diuretics, which are used more for managing high blood pressure rather than edema. Thiazides pull sodium and water out at the distal convoluted tubule and become less effective when renal function is reduced. Except we have the metolazone, which is slightly different than other thiazides, and it continues to work when the GFR is less than 20. Finally, we have K for potassium-sparing diuretics, such as spironolactone. It blocks aldosterone and increases sodium and water excretion while preserving potassium. It can be used in combination with other diuretics and is useful in conditions where aldosterone is involved, such as heart failure, hepatic cirrhosis, and nephrotic syndrome. Several tests are used to measure renal function. An indicator of renal function is serum creatinine. Serum creatinine is the byproduct of creatine phosphate, which is used for energy in muscles. It's produced at a constant rate and is removed from the blood by the kidneys. Increased blood levels indicate a reduction in renal function. The amount of creatinine produced per day depends on muscle mass. Thus, there are different creatinine ranges for males and females, and lower creatinine values in children and those with decreased muscle mass, or it can be diluted with fluid overload appearing to be low. Because the production and excretion of creatinine declines with age, normal serum creatinine values may not represent normal renal function in older patients. Another test used is blood urea nitrogen, or BUN. Urea is a byproduct of the digestion of protein, and small amounts in the blood is normal. However, when BUN level rise, it indicates that the kidneys are not filtering it out. The main causes of increased BUN are impaired kidney function, decreased blood volume as in dehydration, heart failure, GI bleed, rapid cell destructions as in during infections and athletic activity, and others. On its own, BUN is not reliable for assessing renal function, but it can be useful with creatinine in the BUN-creatinine ratio. For instance, a ratio greater than 20 to 1 can indicate dehydration, and if it's greater than 30 to 1, it can indicate a GI bleed. When it's elevated due to renal disease, it's usually closer to 10 to 1. Renal function is reported by calculating glomerular filtration rate, or creatinine clearance. Labs report GFR and they use standard calculations, and clinicians will calculate creatinine clearance for dose adjustments of certain drugs. The glomerular filtration rate reports the volume of blood filtered through the glomerulus into the Bowman's capsule per unit of time. It's accurate only if renal function is stable and creatinine clearance is constant. A normal range of GFR is greater than 90 ml per minute per 1.73 meters square. There are many conditions that cause kidney disease, and the GFR is only one test used to determine renal disease. Some clinicians may not agree with this classification that is listed here, especially in the stage 1 to normal, where in mild renal disease, especially in the elderly with reduced muscle mass, may indicate some renal disease even though they do not have it. The presence of proteins in the urine is another sign of reduced kidney function. Urine that contains protein can appear foamy, although this can be caused by other conditions. Large molecules like proteins usually do not pass through the glomerulus, therefore their presence in the urine is a sign of damage. Because albumin is the dominant plasma protein, it is used in the assessment of kidney function and reported as albuminuria. Because the excretion of albumin varies, it is useful to compare it to urinary creatinine as the albumin-creatinine ratio. This test is inaccurate in people with very high or very low muscle mass due to the variation in creatinine. Some conditions that cause albuminuria are diabetes, hypertension, or cardiovascular disease. Albuminuria can be transient and occur with fever, exercise, inflammatory conditions including toothaches, bowel disease, rheumatoid arthritis, pancreatitis, or psoriasis. For this reason, assessing albuminuria should not rely on one single test and needs to be repeated over several months. Creatinine clearance calculates the amount of creatinine cleared out of the plasma per unit time. Most drug dose adjustments can be done using the GFR reported by labs, but there are still certain drugs with high risks of toxicity, such as chemotherapy drugs and aminoglycoside antibiotics, that are dosed using this equation. It's adjusted for weight, age, and gender, but you have to know which weight to use. Some drugs use actual weight or total body weight, others use ideal body weight. If you're studying for a pharmacology exam, be familiar with this. It might come up in the test. Here's an example of a dosing guide for aminoglycoside. Creatinine clearance has to be calculated, and then drug dosing guides specify which weight to use. Here's an example for an obese person. So first we calculate the ideal body weight, then determine that she's obese, so we calculate the adjusted body weight. This is used in the calculation of the creatinine clearance. After this, we can see her dose of, say, gentamicin will be 7 milligrams times the adjusted weight of 74 kilograms, resulting in a dose of 518 milligrams every 24 hours. Kidneys are very fragile and are easily damaged. Conditions such as dehydration, high blood pressure, diabetes, heart failure, severe burns, surgery, as well as damage from chemicals such as medication, herbs, and toxins can have a significant toll on kidneys. The damage can occur rapidly and be transient if the cause is reversed. It's classified as acute kidney injury if serum creatinine rises rapidly over 7 days, and sometimes the only indication of kidney injury is a decline in urine output. It can be reversed and cause no further problem if the underlying cause is reversed rapidly. If the rise persists for more than 90 days, then it becomes chronic kidney disease and may not be reversible. As damage progresses and becomes permanent, renal function becomes significantly impaired, and GFR less than 15 milliliters per minute is labeled as end-stage renal disease. People with chronic kidney disease will likely be on many medications, as chronic kidney disease is usually accompanied with high blood pressure and or diabetes. Drugs that dilate the efferent arteriole are of particular use in CKD. Commonly used are ACE inhibitors and angiotensin receptor blockers, or ARBs. They lower renal pressure and can slow the decline in renal function. These drugs are started as soon as albuminuria occurs in people with diabetes, even if they do not have high blood pressure. The doses increase as high as tolerated. These drugs may cause a transient increase in serum creatinine, likely due to the drop in pressure in the glomerulus initially. People with heart failure seem to be at higher risk of this, and close monitoring of serum creatinine and potassium is needed after starting an ACE inhibitor or an ARB. Certain drugs are known to be harmful to the kidneys. The most common ones are NSAIDs, such as ibuprofen and naproxen, which may not cause harm in healthy individuals, but can be harmful if used frequently and in susceptible individuals. Other drugs such as aminoglycosides, vancomycin, and amphotericin B are known renal irritants and require careful adjustments of doses and monitoring of renal function. Loop diuretics are often used in renal disease and can be a renal irritant, and they require careful monitoring to ensure that they're safe. Many medications are excreted by the kidneys and require dose adjustments to prevent significant side effects. This list is only a partial list. A common cutoff for dose adjustments is for a GFR less than 30 ml per minute, but some drugs have different limits. Medications have to be carefully selected for safety in people with renal disease. Certain drugs are contraindicated in kidney disease, and here are some common ones. Nitrofurantoin, for example, is an antibiotic for bladder infections. Here, the cutoff uses creatinine clearance of less than 60 based on studies done by the manufacturer before the drug was launched. Nitrofurantoin has to reach the bladder to be effective, and reduced renal function does not allow that. Most other drugs have a cutoff of 30 ml per minute, as this results in accumulation of the drug and increase the risk of side effects. I hope this video was useful. Please leave your comments below and let me know if there are other topics that you'd like me to cover.